I invite the next speaker, Dr. Shyam Mohan, to tell us about the impact of variant pathology on upstaging and survival in patients with NMIBC undergoing cystectomy.
Good morning, everyone. So I will be speaking on the impact of variant histology on upstaging and survival in patients with NMIBC undergoing radical cystectomy. This was published in the Seminars and Original Investigations, Urologic Oncology, and the database was from the Department of Urology, Indiana University School of Medicine. So histological heterogeneity in bladder cancer has significant impact on outcomes, and it is a focus of research topic in the recent years. The efforts to identify variant histology has increased for two reasons. One is it has a clinical and prognostic value. The other is that it is under-recognized in the community. So the incidence of VH in TURBT specimens is around 17 to 20%, while in radical cystectomy specimens is around 33%. The variant histology NMIBC has been categorized as high risk as per practice guidelines due to its aggressive behavior. And early radical cystectomy, that is timely radical cystectomy, has been recommended in the guidelines for high and very high risk pure urothelial NMIBC. However, there is limited data on patients with variant histology in the NMIBC setting. So variant histology, we generally encounter variant histology in the muscle-invasive setting. There are few studies that analyze the role of variant histology in non-muscle invasive setting, where BCG therapy has not understaged the tumor as it has in pure urothelial carcinomas. So the hypothesis is that the variant histology NMIBC would demonstrate higher upstaging and worse overall survival after radical cystectomy compared with pure urothelial NMIBC tumors. The method was the Indiana University bladder cancer database was used to identify cases between 2004 to 2020. 42 patients with variant histology were identified, and over the same time with pure urothelial carcinoma patients were also identified to perform a matched pair analysis. So upstaging was defined as any shift from lower clinical stage to higher pathological stage following radical cystectomy. So these are the demographic and clinical variables that have been matched: the age, gender, prior intravesical therapy, presence of muscularis propria on the TURBT specimens, presence of CIS. So as we can see, the odds ratio of upstaging at RC for variant histology NMIBC is 4.33 compared to the pure urothelial NMIBC. Similarly, the lymph node positivity in variant histology is statistically significant compared with pure urothelial NMIBC. Here we see the distribution of pathological staging after radical cystectomy. Again, the upstaging of variant histology to PT3 and PT4 was found statistically significant compared with pure urothelial carcinomas. Here, the Kaplan-Meier survival curves were used to estimate the overall survival between variant histology and pure urothelial NMIBC. The median survival for variant histology was 28.4 months compared to 155 months for pure urothelial NMIBC. And the impact of time from final TURBT to radical cystectomy was also analyzed. So there was no statistical significance as when the timing of RC from radical cystectomy from the final TURBT was seen. The three groups were less than 30 months, 30 to 60 months, and greater than 60 months. It was not proved to be statistically significant. As we can see, the sarcomatoid and plasmacytoid variant, the percentage upstage for these two variants, which was much higher compared to the other variants. However, when they were compared to the pure urothelial or amongst themselves, it was not statistically significant. So this study, it reports a higher incidence of upstaging in variant histology NMIBC following radical cystectomy compared to pure urothelial NMIBC, and underscores the aggressive behavior of this histology in the NMIBC setting with poorer overall survival. Shapur et al. Has shown higher rates of disease progression in variant histology. compared to the pure urothelial NMIBC. Similarly, Goffret et al. Had observed significantly worse progression at 5 years when comparing variant histology to pure urothelial NMIBC despite giving BCG therapy. So there is a shift in diagnostic and therapeutic strategy to improve the outcomes for this variant histology cohort of patients. The recommendations are to improve the classification schemes, to improve the clarity of treatment strategy. Adjunct molecular profiling has shown value in demonstrating the role of neoadjuvant chemotherapy in downstaging the disease. However, further studies are required. The strength of the study was, this was a matched pair case control study design. The variant histology was confirmed by experienced genitourinary pathologists, and also the surgery was performed by in high volume centers. This is a broadly inclusive study including the prior intravesical therapy, the varied time from TURBT to radical cystectomy, and the percentage of each variant histology was also included, which gives us a real world scenario and provides value for the patient counseling and determination of treatment course. The limitations were the retrospective design, which introduces the inherent bias, the small sample size and limitations in follow-up, preventing adequate capture of timing of disease progression. So again, not all TURBTs were performed in the parent institution, which may have resulted in inadequate resection and resulting in which may have affected the true clinical staging and upstaging rates. So this study has provided a meaningful contribution to the understanding of behavior of variant histology with a matched pair study design. There is strong consideration for upfront radical cystectomy even now, since BCG has not proven to be effective in downstaging the disease, and even bladder preservation therapy has not proven to be effective. Further studies are warranted to establish the role of neoadjuvant systemic therapy using molecular profiling. Thank you.